Describing the sample versus the target population is about being clear on who your data actually represent and who you want your conclusions to apply to. The sample is the set of observations you have in your data set, which could be patients seen in certain clinics, survey respondents who chose to respond, program participants who enrolled, or records captured by a specific system. The target population is the broader group you care about, such as all eligible residents in a region, all clients served by a program, or all people who would be affected by a policy. These two groups are often not identical, and the gap between them is a major source of misinterpretation. For example, clinic data often represent people who accessed care, not everyone who needed care. Another example, survey data represent respondents, not everyone who was invited. A third example, program evaluation data represent people who enrolled, not everyone eligible. A practical reason this distinction matters is that descriptive statistics can look precise, even when the sample is not representative. You can compute an accurate mean or percentage for the sample, but that number may not generalize to the target population if selection into the sample is uneven. For example, if higher income individuals are more likely to respond to a survey, the sample's average experience may differ from the target population's experience, even if your calculations are technically correct. Another example, if people with more severe conditions are more likely to be captured in a hospital dataset, the sample's outcome rates may look worse than rates in the broader community. A third example, if a program serves mostly motivated participants, the sample may show high completion matter, even if completion would be lower among the full eligible population. The descriptive statistic is not wrong, but the interpretation becomes wrong if you assume the sample equals the population. The first step is to define inclusion and exclusion clearly, because that tells you how the sample was created. Inclusion criteria are the rules that determine who gets into the dataset, such as age ranges, eligibility conditions, service use, geographic boundaries, time windows, or participation requirements. Exclusion criteria are rules that remove records, such as missing key identifiers, implausible dates, or ineligible statuses. For example, if you analyze outcomes among people with at least one visit, you are excluding people with 0 visits, which changes the meaning of rates because you are looking at users rather than all eligible individuals. Another example, if a dataset includes only people with complete follow-up, your sample may overrepresent those who are easier to reach and underrepresent those who drop out. A third example, if records from one region are missing due to extraction issues, the sample is unintentionally restricted and any statewide description is incomplete. A strong descriptive section often compares the sample characteristics to what is known about the target population, even if you can only do this at a high level. This comparison helps reveal whether the sample is skewed. For example, you might compare the age distribution in the sample to the known age distribution in the population, noting whether younger or older individuals are underrepresented. Another example, you might compare the geographic distribution of the sample to the distribution of the population across regions, noting whether some regions contribute disproportionately to the dataset. A third example, you might compare key demographic or risk factors if population benchmarks exist, such as overall percent insured, overall race and ethnicity distribution, or baseline prevalence of a condition. When benchmarks are not available, you can still describe the sample in enough detail that readers can judge plausibility and potential bias. It is also useful to be explicit about the difference between descriptive goals, describing what happened in the observed data versus estimating what is true in the population. Describing what happened in the observed data is often the correct goal for operational monitoring, quality improvement, or service workload planning, because the dataset reflects the system being managed. For example, a clinic manager may only need to know the completion rate among people who attended, because that is the operational reality. Estimating what is true in the population is often the goal for public health monitoring, policy planning, and generalizable research, because decisions affect people beyond those observed. For example, a policymaker may need to know population rates, not just rates among service users. Being clear on which goal you have prevents a lot of confusion and helps you decide whether you need weighting, standardization, or other adjustments to align the sample with the target. Finally, clear communication is part of describing sample versus target population. This includes stating the data source, the time frame, and the unit of observation, and then stating what group the results apply to. For example, you might describe results as applying to individuals captured in the dataset during the specified period, rather than implying they represent all eligible individuals. Another example is to explicitly state when the dataset excludes people not engaged in services, which can lead to underestimation or overestimation, depending on context. A third example is to use careful language like "in this sample" or "among observed records," which keeps interpretation grounded. This habit makes your descriptive statistics more transferable across jobs, because you can apply the same logic whether you are working with clinical data, program data, survey data, or operational data sets. A numerator and a denominator are the two parts that define most descriptive statistics that matter in applied biostatistics. The numerator is the number of events or people that meet a condition, and the denominator is the group you are comparing that numerator to. The meaning of a percentage, proportion, or rate depends entirely on whether the denominator matches the question. If the denominator is wrong or inconsistent, as the statistic can look legitimate while answering a different question than intended. For example, number of people who had an outcome divided by number of people eligible describes risk or prevalence in the eligible group. Another example, number of visits with a service divided by total visits describes how common the service is per visit, not how common it is per person. A third example, number of events divided by time at risk describes a rate, which is a different concept than a proportion and is often more appropriate when follow-up differs. Proportions and percentages usually use a denominator that counts people or units, not time. These are good for describing how common something is within a defined population at a point or within a defined period. Examples include percent of participants who completed a program, percent of patients who received a screening, or percent of sites meeting a quality threshold. In these cases, the denominator is often number eligible or number observed, and the numerator is number with the outcome. The key is to state eligibility clearly, because eligibility defines who should be counted in the denominator. For example, if a screening is recommended only for a subgroup, the denominator should be that subgroup, not everyone. Another example, if a program completion outcome is only meaningful for participants who started the program, the denominator should be starters, not everyone who was invited. A third example, if your dataset only includes service users, your denominator is service users, not the whole community. Rates bring in the idea of time, which is where person-time intuition becomes essential. A rate answers how often events happen per unit time, not what fraction of people had an event. This matters when different people are observed for different lengths of time or when the opportunity for events differs. Person time is the total time that all individuals contribute while they are at risk of the event. For example, if one person is followed for 12 months and another for 6 months, together they contribute 18 person months of observation. If they had 3 events total during that time, the rate is 3 events per 18 person months, which can be expressed as events per person year or per 100 person years, depending on reporting preference. Another example, in workplace safety, hours worked are often the time denominator, so incidents per 100,000 hours worked compare risk across teams with different workload volume. A third example, in program monitoring, person time can represent time enrolled or time eligible, which helps compare event frequency when enrollment length varies. Person time helps you compare fairly when follow-up differs or when participation starts and stops. Without person time, raw counts and even simple proportions can be misleading. For example, if one group is observed longer, it will naturally accumulate more events, even if the underlying event frequency is the same. Another example, if one clinic has better retention, it may observe more follow-up events simply because it has more observed time, not necessarily because the underlying rate is higher. A third example, in system performance monitoring, if one unit processes more volume or operates more hours, it will naturally have more opportunities for errors or delays, so comparing raw counts is unfair. Rates adjust for this by scaling events to the time or exposure opportunity. This is why rates are often preferred for comparing event burden across groups with different exposure time. Getting denominators right also includes deciding whether the denominator is people, events, opportunities, or time. Each leads to a different statistic that answers a different question. People-based denominators answer questions about reach, risk, or prevalence. Event-based denominators answer questions about how often something happens per encounter or per transaction. Opportunity-based denominators answer questions like what proportion of eligible opportunities included the action, which is common in quality measures. Time-based denominators answer questions about frequency over time, which is common in incidence and operational rates. Examples make the contrast clear. Percent of people screened differs from percent of visits with screening, and both differ from screenings per 1,000 person years. Number of incidents differs from incidents per 100 employees and differs from incidents per 100,000 hours worked. None are automatically best. The right one depends on what decision the statistic supports. A useful habit is to write the statistic as a sentence before calculating it with the numerator and denominator explicitly named. This forces clarity and prevents silent denominator drift. For example, you would phrase a proportion as number of eligible individuals who experienced the outcome during the period divided by total number of eligible individuals during the period. You would phrase a rate as number of events during the period divided by total person time at risk during the period. You would phrase an encounter-based statistic as number of encounters with the service divided by total encounters. This sentence habit also makes it easier to detect when different parts of a report are mixing denominators, which can confuse readers and undermine trust. Finally, person-time intuition supports clearer interpretation. A rate is not a probability and should not be interpreted as a percent of people who will have the event. It is a frequency measure. A practical way to keep this straight is to think of a rate as a speed, events per unit time. For example, 2 events per 100 person years communicates that events are relatively rare across time at risk. Another example, 15 incidents per 100,000 hours worked communicates risk scaled to exposure time. A third example, 0.8 visits per person month communicates utilization intensity. This framing is transferable across settings and jobs because it is grounded in the denominator logic rather than in a specific data set. Crude rates are the raw rates you calculate directly from the observed numerator and denominator without accounting for differences in population composition. SASH. Adjusted rates are rates that have been modified to allow fairer comparisons across groups by accounting for differences in key factors that affect the outcome, such as age distribution, sex distribution, baseline risk, or other structural differences. The reason this matters is that crude rates can differ across groups even when the underlying risk is similar, simply because the groups have different compositions. Adjusted rates are designed to answer a different question. What would the rate look like if groups had the same composition on selected characteristics? For example, comparing crude disease rates across 2 regions can be misleading if one region has an older population. Another example, comparing crude hospitalization rates across clinics can be misleading if one clinic serves a higher risk patient population. A third example, comparing crude injury rates across work sites can be misleading if one site has more high-risk job roles. Crude rates are still valuable because they reflect the actual observed burden. If you are planning resources, staffing, or service capacity, crude rates and crude counts often matter most because they reflect what is truly happening in the system as it operates. For example, a clinic manager needs to know the actual number of emergency visits and the actual visit rate among their patients to plan staffing. Another example, a program director needs to know the actual proportion of participants who completed because that is the operational performance. A third example, a public health planner may need crude counts and crude rates Spornfrakrei to understand where absolute burden is highest, because that is where services may be needed. The key is to interpret crude rates as real observed outcomes in the existing population, not as a pure measure of underlying risk, stripped of composition differences. Adjusted rates are valuable when the goal is comparison, especially comparisons that imply differences in performance, risk, or effectiveness. Adjustment helps reduce confounding from structural differences in who is included in each group. A common form is age adjustment, where rates are standardized to a common age distribution so that groups can be compared as if they had the same age mix. Another example is risk adjustment in healthcare quality measurement, where outcomes are adjusted for baseline risk factors so comparisons across providers are fairer. A third example is adjusting for differences in exposure opportunity, such as adjusting injury rates for job mix or adjusting outcome rates for baseline severity. Adjustment does not make comparisons perfect, but it can make them substantially more interpretable by addressing major known drivers of the outcome. There are different ways to adjust rates, and the approach should match the type of data and the purpose. Direct standardization is a common method when you have stratum-specific rates, such as age-specific rates and a standard population distribution. You compute what the overall rate would be if your group had the standard distribution across strata. Indirect standardization is often used when stratum-specific rates are unstable in a small area or small subgroup. It uses external rates to compute expected counts and then compares observed to expected, which produces a standardized measure like a ratio. Regression-based adjustment is used when you want to adjust simultaneously for multiple covariates and estimate adjusted outcomes or predicted rates from a model. These are different tools for the same goal: fairer comparisons by accounting for key differences in group composition. The choice between crude and adjusted rates depends on the message you need to communicate and the decision the metric supports. Crude rates communicate burden in the real world as observed. Adjusted rates communicate comparison on a more level playing field. Both can be reported together because they answer different questions and can complement each other. For example, a region might have a high crude rate because it has an older population, while its adjusted rate is similar to other regions, which suggests the high burden is driven by population structure rather than higher underlying risk. Another example, a clinic might have a high crude complication rate because it treats higher risk patients, but an adjusted rate might show performance closer to average. A third example, a work site might have more incidents because it has more high-risk roles, but adjusting for job mix could show that its incident risk per role is not unusually high. Adjusted rates also require careful communication of locally, because they depend on which factors you adjust for and what standard you use. If you adjust for different variables or use a different standard distribution, adjusted rates can change. That does not mean adjustment is wrong. It means adjustment is conditional on the chosen framework. For example, age-adjusted rates depend on the chosen standard population distribution, and different standards can produce slightly different adjusted values. Another example, risk-adjusted provider outcomes depend on the set of risk factors included in the model and how they are measured. Missing risk factors can leave residual confounding. A third example, if you adjust for a variable that is actually part of the pathway of an intervention, you may remove part of the effect you care about, which changes the meaning of the adjusted comparison. This is why adjusted rates should always be presented toward, with a clear statement of what was adjusted for. Finally, both crude and adjusted rates should be interpreted with attention to uncertainty, especially for small numbers. Small numerators lead to unstable rates, and adjustment does not automatically fix that. In fact, adjustment can sometimes increase variability when data are sparse within strata. A practical habit is to look at numerator counts, denominator size, and confidence intervals, or other uncertainty measures when comparing rates. For example, two areas may have different crude rates, but overlapping confidence intervals, suggesting the difference may be due to random variation. Another example, An adjusted rate for a small subgroup may be unstable because stratum-specific information is limited. A third example, trends over time in adjusted rates may be influenced by changes in population composition or coding, which should be monitored alongside crude counts. Using crude and adjusted rates together, with transparency about methods and uncertainty, is how descriptive statistics remain both honest and useful. Stratification means breaking your summaries into meaningful subgroups so you can see whether patterns are consistent across groups or concentrated in specific groups. Instead of reporting one overall mean or one overall rate, you report the same statistics separately within categories such as age group, sex, region, baseline risk level, or service setting. Stratification is one of the most practical descriptive tools because it reveals heterogeneity that an overall average can hide. It also helps you understand whether differences between groups might be driven by population composition. For example, an overall rate might look stable while one subgroup's rate is rising and another subgroup's rate is falling. Another example, an overall completion percentage might look high, while a subgroup with high need has much lower completion. A third example, an overall burden count might be dominated by one region simply because it has a larger population, and stratification helps separate size from rate. A good stratification strategy starts with choosing subgroups that are meaningful for interpretation and decisions, not just easy to calculate. Meaningful subgroups often reflect known differences in risk, access, exposure, or context. Examples include age group, because many outcomes vary strongly by age, geography, because resources and environments differ, and baseline status, because starting level often influences outcomes and needs. In many contexts, service setting or site can also be meaningful, because practices and populations can differ by location. Another useful subgroup type is time period, such as year or quarter, which supports trend interpretation. The goal is to choose subgroup definitions that map to plausible differences in the real world and to the decisions your audience needs to make. Stratification also requires disciplined denominator thinking, so each subgroup statistic is comparable. Each stratum must have a clearly defined denominator that matches the numerator definition within that stratum. For example, if you stratify by age group, the denominator for each age-specific rate should be the population or person time in that age group, not the overall population. If you stratify by region, the denominator should be region-specific eligible population, not the statewide eligible population. If you stratify by a service setting, the denominator should reflect who is actually eligible or observed within that setting. A common pitfall is accidental denominator drift, where numerators are stratified but denominators are not, creating subgroup rates that are not true rates. Clear stratified denominators keep the comparisons honest. Stratification is also a tool for identifying potential confounding and effect modification at the descriptive level. If an overall difference between two groups disappears or reverses when you stratify by a third variable, that suggests the third variable may be a confounder or a key structural driver. For example, if one region has a higher crude rate than another, but within each age group the rates are similar, then the crude difference may be driven by age distribution differences, rather than higher underlying risk. Another example, if one program appears more effective overall, but within baseline risk levels the difference is small, then the overall difference may reflect that the program group started with a different risk mix. A third example, if an exposure effect appears strong only in one subgroup and not others, stratification can reveal that the relationship is not uniform, which is the descriptive signal of effect modification. These insights inform whether adjusted comparisons or interaction modeling may be needed later. Practical stratification also requires attention to small numbers and instability. When a subgroup has a small denominator or a small numerator, the resulting rate can bounce around due to random variation, making it easy to overinterpret noise. For example, if a small county has only a few events, a single additional event can change the rate dramatically. Another example, a rare outcome within a small subgroup can produce extreme percentages that look alarming but are based on very small counts. A third example, stratifying too finely, such as using many categories at once, can fragment the data and produce sparse cells across the table. Good practice is to report subgroup counts alongside rates and to consider collapsing categories when cells are too small to interpret reliably. This is also where confidence intervals or other uncertainty measures help prevent overconfidence. Another practical consideration is that stratification can be done one variable at a time or as cross-stratification across two variables. One variable stratification is easier to communicate and often the best starting point. Cross-stratification, such as age by region or age by sex, can reveal patterns that single stratification misses, but it increases complexity and can create sparse cells. Examples include comparing regional rates within each age group to separate composition from risk, or comparing outcomes by baseline risk within each intervention status group to see whether patterns differ at different starting levels. Cross-stratification is most useful when the two variables represent different structural dimensions, such as demography and geography, or baseline risk and exposure group. The trade-off is that cross-stratification requires careful table design, so it remains readable and does not overwhelm the audience. Finally, stratification is most effective when paired with clear communication about what the subgroup results mean. Subgroup differences do not automatically imply unfairness, causality, or program failure. They are descriptive signals that something differs across groups and that the difference may warrant further investigation. For example, a subgroup with a higher outcome rate may have higher underlying risk, different access, different measurement completeness, or different exposure patterns. Another example, a subgroup with lower completion may face structural barriers that are not visible in the dataset. A third example, a subgroup with different rates may reflect differences in data capture, especially if missingness varies by subgroup. Descriptive stratification sets up deeper analysis by showing where patterns are and by ensuring your overall story is not hiding important differences. A good table communicates the statistic, the denominator, and the comparison without forcing the reader to guess. In biostatistics, most confusion comes from tables that hide what the numbers represent or mix different denominators in the same display. Clear tables make it obvious whether you are describing people, events, or person time, and whether the numbers are counts, percentages, rates, or adjusted values. A strong table also makes it easy to scan. Readers should be able to find the main comparisons quickly and understand what each column means without reading a long paragraph. For example, a table of baseline characteristics should show how groups differ in key features that affect interpretation. Another example, a table of rates by subgroup should show both the numerators and denominators, so stability can be judged. A third example, a table of crude and adjusted rates should label the adjustment clearly, so the reader does not treat adjusted values as raw burden. A common convention for categorical variables is to report n%, where n is the count in the category, and percent is the percentage within the relevant denominator. This works well for baseline tables and subgroup description because it shows both magnitude and proportion. The key is to define what the percentage is out of. For example, in a two-group baseline table, the percent is often within each group column, so each group's percentages add to 100% within that variable. Another example, in a single sample descriptive table, the percent is often out of the full sample size. A third example, when missingness differs across variables, the denominator can silently change unless you state whether the percentage uses all records or only non-missing records. A clean approach is to either include a missing row for each variable or to show the non-missing denominator next to the variable name. This prevents the reader from assuming a stable denominator when it is not. For continuous variables, a clear convention is to report either mean, standard deviation, or median interquartile range, depending on distribution shape. The table should not mix these formats within the same variable, so unless you intentionally want to show both, because that makes scanning harder. If you do show both, it helps to use separate rows or separate columns labeled clearly. Examples include reporting age as mean, standard deviation, when it is roughly symmetric, and reporting cost as median interquartile range when it is skewed. Another example is reporting wait time as median, while also adding a 90th percentile column if tail performance matters. A third example is reporting length of stay with median and percentiles rather than mean when there are extreme long stays. The main principle is consistency across the table, so readers can compare rows without recalculating in their heads. For rates, tables should make the numerator and denominator explicit, and the denominator should be in the same unit across rows. A clear convention is to present rate alongside the count of events and the exposure, such as events, person time, and rate per unit time. For example, you might show number of events, total person years, and events per 100 person years. Another example, for occupational outcomes, you might show incidence, total hours worked, and incidence per 100,000 hours. A third example, for geographic outcomes, you might show events population and rate per 100,000 population. This structure prevents misinterpretation because the reader sees the scale and can judge stability. It also discourages comparing rates across rows when the denominator unit changes. Rates become much clearer when the table keeps the unit constant and labels it in the header. When presenting crude versus adjusted rates, a clear table design separates observed burden from adjusted comparison. One clean structure is to include crude counts and crude rates in one set of columns and adjusted rates in a separate column, with a footnote stating what variables were adjusted for and what standard was used. Another structure is to provide two tables, one for crude burden and one for adjusted comparison, which avoids crowding and prevents readers from confusing adjusted numbers with raw burden. Examples include a county table that shows crude counts and crude rates per 100,000, paired with an age-adjusted rate column for fair comparison across counties. Another example is a provider table showing observed outcome rate and risk-adjusted outcome rate. A third example is a time trend table showing crude rates over time, and then a standardized series that holds composition constant. The key is to label adjustment in plain language and to keep adjusted numbers from visually blending into the crude burden columns. Stratified tables should be designed to help scanning across strata without overwhelming the reader. A common format is one row per stratum and columns for numerator, denominator, and the statistics such as percent or rate. If multiple groups are being compared within each stratum, a common format is one row per stratum and separate columns for each group, plus a column for the difference. Another approach is a two-panel table, where each panel is one group, but panels should still share identical row ordering and identical statistic definitions. Examples include a table of outcome rates by age group, with separate columns for two regions, and a column showing the difference between regions within each age group. Another example is a table of completion by baseline risk category with separate columns for intervention and comparison groups. A third example is a table of rates by quarter with clear row ordering so trends can be seen. The main principle is to avoid overly wide tables that force horizontal scrolling or make it hard to keep track of which column you are reading. Finally, table clarity improves when you use consistent labels, consistent decimal precision, and thoughtful ordering. Consistent labels mean using the same category names across tables and figures, so readers do not have to translate. Consistent decimal precision means you do not show 3 decimals in one row and 0 decimals in another, unless there is a reason, because inconsistent precision can imply false differences. Thoughtful ordering means ordering categories in a way that supports interpretation, such as ordering age groups from youngest to oldest, ordering time periods chronologically, and ordering regions in a stable, familiar sequence. If a table includes many rows, it can help to add a total row and then group rows with subtle separators, but the content should remain readable without special formatting. The overall goal is that the table communicates the story of the data with minimal cognitive load and without inviting denominator confusion.